Welcome. We're discussing pre-implantation genetic testing, barriers to access, and the hashtag is PGT Access. This event is taking place due to the generous support of the D'Oyly Carte Charitable Trust. I'm Sarah Norcross, Director of PET, and I'll be chairing the discussion. So I wanted to sort of give you some background before we kick off with the speakers. And pre-implantation genetic testing for monogenic conditions or a single gene is known as PGT-M, and pre-implantation genetic testing for structural rearrangements is known as PGT-SR, and they are the main focus of tonight's discussion. Now, PGT-M used to be known as PGD, pre-implantation genetic diagnosis. And that was back when the world was, I feel, a somewhat simpler place. So I hope I've not already lost you with some of you with these acronyms. They're widely used in the sector and will probably end up, I think, inadvertently flitting a little bit between PGTM and PGD because sometimes it depends what period of time you're talking about. And if you're talking well, from a while ago, it was always called PGD and it's sort of quite difficult to sort of flip. But if you have any difficulties and get lost in any acronym soup that might occur this evening, then please do put a question in the comments so that I can try and clear it up for you as soon as possible. And I think it's important to sort of think about um, PGTM or PGD and how old it is, because the first pregnancies and live births following in vitro fertilization and pre-implantation genetic testing or diagnosis, as it was known then, were reported in 1990. Professor, now Lord Robert Winston, and Professor Alan Handyside, leading a small group at the Hammersmith Hospital in London, published a report in Nature on these very first pregnancies involving IVF, embryo biopsy, and genetic screening for inherited disease. And this was in several couples who are at risk of having children with various X-linked conditions. And there's a link to that paper for you in the chat. Now, the timing of that report in Nature, a week ahead of the decisive free vote in the House of Commons on the Human Fertilisation and Embryology Bill, was no coincidence. The then editor of Nature was adamant that this work, which demonstrated the potential benefits of allowing human embryo research, should be in the public domain to inform the national debate. So, to meet the tight publication deadlines, the paper was submitted, peer reviewed, and accepted within days. Now, I can imagine academics and people's jaws dropping, thinking, blimey, to have something in Nature after sort of a few days, like, when it actually can take months, if not years. Um, it's quite something. But Nature really wanted to get maximum publicity for this, and they also organised a press conference. And that bill was subsequently passed by a substantial majority, and it included a provision for PGD, as it was then, for serious conditions and also for human embryo research. And you can read more about this interesting bit of the history of it, which has been written by Alan Handyside when it was the 30 years of PGD, and there's a link to that article in the chat. And then to skip forward in 2008, the amendments to the Human Fertilisation and Embryology Act sanctioned the HFEA licensing the process and made explicit the limits to the use of PGD. For example, embryos known to be at risk of serious mental or physical disability or serious illness must not be preferred to embryos where there is no such risk. And then sort of jumping forward again to 2013, and that is when the clinical commissioning policy for pre-implantation genetic diagnosis was published. I know one of the speakers is going to go into more detail of that, so no spoilers from me about the access criteria. And so now, looking at the Human Fertilisation and Embryology Authority's website, PGT-M can currently be used to avoid the transmission not to avoid more than 1,700 genetic conditions. Um, and as I've touched on commissioning slightly, PGTM is commissioned centrally on the NHS, meaning that it's not subject to the same postcode lottery that fertility treatment is, and that people are used to me banging on about at great length. But there are still issues surrounding its accessibility. And last year we published a comment piece entitled Equity of Equity of Access Not for Northern NHS Patients Requiring PGT-M. And that was written by Dr. Alyssa Baskind and Dr. Tony Rutherford. And as I was preparing for this, I do what I normally do. I searched Bionews and looked through the archive, and found that there are more than 400 articles that mention PGD or PGT. Too many for me to read for my short intro. But if you want to read more about this topic to find out how it's developed and changed over the years, then Bionews is an excellent place to start. So tonight we're going to be discussing what PGT-M can and should be used for, why it can be difficult for some patients to access it, and what might be done to remove the barriers to access. Our first speaker this evening is Charlotte Tomlinson. Charlotte is a consultant genetic counselor and clinical genetics PGT lead at Guy's Hospital. She's also a consultant genetic counselor at DNA Connect and at London Embryology, and she's a contributor to the book Problem Solving in Cancer and Fertility.
Right, so thank you for the introduction. So Sarah's obviously introduced the concept of preimplantation genetic testing, but it basically uses fertility treatment to create embryos, which then undergo a biopsy. And that means that several cells are removed from the embryo at the blastocyst stage, and those cells have DNA extracted, and they're tested for either the single inherited genetic condition, for example, something like myotonic dystrophy or something like Huntington's disease, or it can be to look for an inherited form of chromosome rearrangement. So like one of the common chromosome rearrangements, such as where chromosome 21 is attached to chromosome 13. And so with these types of inherited conditions, there is anywhere up to a 50% risk of each embryo inheriting that result and therefore having that genetic condition, or with the chromosome rearrangements having some kind of unbalanced form, so which can cause the significant effect on that future child and adult when they grow up. These are the types of conditions that are funded through NHS-funded PGT, and they are diagnostic tests to give you an answer about that inherited risk. There is also other types of preimplantation genetic screening that goes on in relation to potentially looking at events where in a single embryo there may be a change in the number of chromosomes, which is described as preimplantation genetic testing for aneuploidy. But this is not something that's funded through the PGT NHS England pathway or the other devolved nations. So this is just to give, for some of you who've not familiar, an idea of why a couple or a family might opt for PGT. So we've got several examples on our Guy's and St Thomas's website. So in this case, this couple have a son affected by an X-linked condition called Duchenne muscular dystrophy. It's a severe life-limiting condition. Most boys are affected from about 2 and will unfortunately pass away in their 20s or 30s after having had a very significant impact on their quality of life. So I think this patient describes very well that what PGT, or as was the term they used when they underwent treatment, does for them is it takes away the scariest decision parents have to make, which is whether to have a termination. And that whichever decision, if they're having to face that decision around ending a pregnancy that's affected, you make in that situation, you are left with lifelong emotional scars. And so what PGT can do is give families in these very difficult situations the choice to try and have a child unaffected by that genetic condition and not being put in that situation where they have to make that kind of decision. So the PGT service at Guy's and St Thomas's has been running since 1997, and we carry out more than 60% of all NHS PGT cycles in the UK. We've completed treatment for over 450 separate genetic conditions. And in 2019, we had more than 1,000 babies born, so we're well on our way to 2,000. And the oldest baby born through PGT is in their 20s. One of the issues that's raised, obviously, is around geography and access to treatment. That, as a service, we've tried to address historically by having satellite services in Leeds, Sheffield, and Exeter. So the fertility treatment takes place locally, but the egg collection and then the genetic testing from the embryos and the embryo transfers would all take place at Guy's Hospital. So it does still involve travel, significant travel for those families, but it's to try and reduce some of that travel they have to make. In addition, as well as our service within England, there's the Centre for Reproductive and Genomic Health in London, Oxford Fertility, the Birmingham PGT service, and Care Nottingham that offers English-funded PGT. And then there's centres in Scotland, and our service tends to provide most of the PGT for Wales and Northern Ireland. So the patient journey. So a couple are normally seen for genetic counselling through a local clinical genetics service, and that's what's stipulated in the current NHSE funding policy. And that appointment is there to help the couple understand, or their individual, the accurate reproductive risk, to talk about their reproductive options, what service, if they want to be referred to PGT, they could be, and whether they're eligible for NHS-funded PGT. It's also there, I guess, to help them understand emotionally which may be the best choice for them as an individual or as a couple in planning a family. They would also help assess whether the genetic mutation report is up to the current scientific guidelines, which are changed every 2 years. And so they will combine all that information and make the referral to a PGT service such as our own. We will then do a in-depth PGT triage, where we will look to assess the genetic information on that person and potentially what other testing has occurred in other family members, to ensure that we can technically offer PGT, because some of the tests are designed around that particular individual and that particular genetic mutation. We will also assess for medical information, particularly around the female partner, in relation to the risks of PGT and in pregnancy, so around cardiomyopathies or vascular conditions like vascular EDS. And sometimes we may require an anaesthetic review in advance of even accepting them onto the PGT pathway. However, once accepted, we will see them for an initial appointment where we have PGT videos to help patients see what it will be like in theatre, what happens to the embryos. And then we have a one-to-one appointment where we address any specific concerns and the specific genetic information around the testing that will occur on their embryos. For some families, we may need to, if it's a new condition, apply for a HFEA license. And we may also need to collect DNA samples from family members and potentially undertake some testing prior to referral for fertility treatment to ensure we can definitely design an accurate test. They will then be seen in the assisted conception unit for their fertility assessments. And then they would usually start treatment after that, which would involve typical IVF to hopefully result in egg collection with a sufficient number of eggs. The male partner would give the sperm sample. We would use ICSI to fertilize the eggs, and then see how many fertilized eggs develop to day 5 or 6 to become a blastocyst. Only about a third usually develop to that stage from what was started at the beginning. And then the embryology team will use their skill to biopsy those embryos, extract some cells from each embryo, and they will go off to our genetics lab for testing. The genetic testing can take anywhere between 1 to 4 months, depending on the particular genetic condition and the makeup of the family in relation to how the test is designed. And then the embryology team would usually call them after that to give them the result. Up to some of the conditions, the risk is 50-50, so it is possible that there are no embryos available after one cycle and they will have to start that process again. Otherwise, if there are embryos available, they can then be booked for an embryo transfer. There is, of course, highs and lows to this process, and so there is psychological support offered through fertility counselling, through the fertility coaching service with an embryologist, and also we've now developed a group support session following feedback from patients. The team at Guy's is made up of many different professional groups. So we have the genetic counsellors and geneticists, and we do liaise with the whole of our clinical genetics service in relation to some queries around certain medical conditions. We have the ACU team of the fertility doctors, the fertility nurses, the embryologists. We have the fertility and the scientists in the PGT lab, both the monogenics lab, which are the single genes, and the cytogenetics lab, which are the structural rearrangements. We have all the administrative teams across all those services. We also have the fertility counsellors, the psychology service, which is set in genetics, and the fertility coach. We have daily exchange about some patients as needed, and we have a weekly MDT where all these professionals attend to make sure that we're giving our patients the best service we can. So a registered genetic counsellor within this role will usually help families or patients and couples to understand their risk of the genetic condition and what PGT can give them in relation to tests on the embryos. It can also be helpful to use counselling skills to help patients reality test what that process may look like for them, and to be prepared for the marathon process that is PGT. And obviously that is something that's also done by the local clinical genetic services in supporting these patients to come to PGT in the first place. Genetic counselling practice is standardised by the Genetic Counselling Registration Advisory Board, and any genetic counsellor that is registered would be on the Academy of Healthcare Science or Healthcare and Professionals Council, and some may also have NMC membership as well. So moving on to sort of the main part of this around barriers of PGT or patients. So the criteria for NHS funding was published in 2014 and was meant to be updated in 2018. And we're still now in 2025 waiting for that update. There has been a working group set up by NHS England to look at and revise the policy, but we're still waiting for a new updated policy. So the original policy states that the NHS England policy that female patients must be under 40 years at the start of treatment. Within our service, it's not always, and for others, it's not always possible to offer PGT to women over 39 years of age, depending on the complexity of that history and the genetic testing that may be involved. The female body mass index must be between 19 and 30. The couples must have been in a stable relationship. The key, and it mentions couples, but there's been clarity that obviously we have been able to offer treatment to same-sex couples and single individuals when in conversation with PGT commissioners. And that's something that the new policy was going to bring more clarity about. One of the key problems for people with late onset genetic conditions are that the current policy states that couples with healthy children together or untested children can be accepted for PGT, but they'll not be eligible for NHS funded PGT, which is very difficult when there's maybe been a diagnosis of a late onset condition like hereditary breast cancer, BRCA1, or Huntington's disease in a family. The eligibility criteria for England varies for devolved nations. So Wales, Scotland, Northern Ireland have their own policies.
Next this evening, we have Dr. Melanie Nana, and Melanie is a clinical research fellow at King's College London and an obstetric medicine fellow at St Thomas's Hospital. And Melanie was previously co-chair of the Trainees Committee of the Royal College of Physicians.
I'm going to talk about managing women with medical conditions, in particular genetic conditions during a pregnancy. Because, as Charlotte mentioned, many of these women will have a condition themselves. And we have to think in the preconception period, ideally, how are we going to make sure that they get through the pregnancy themselves in a safe manner? So this is a snapshot from the Embrace report, which is a confidential inquiry into all maternal deaths across the UK. And essentially what it shows on the right-hand side is that women in pregnancy no longer die of sepsis and bleeding. They die of medical complications. These include thrombosis, COVID, and cardiac disease. And over 50% of women who will die during pregnancy now have a pre-existing medical condition. And it's recognised that in 50% of these patients that there could have been improvements to their care that would have made a difference to their outcome. So in many senses, if you're having patients who are being referred for pre-genetic testing, IVF, this is an opportunity to determine that a woman may benefit from pre-pregnancy counselling, where we can talk about the risks of pregnancy for her. And we always say that we want to get the patient and the partner and the baby through the pregnancy successfully, not just give them a baby, but a healthy baby that's closest to term as possible. So I thought I'd share one case and talk about a couple of commonly referred problems. So this was a lady who was referred from Guy's who had a background of what we call dilated cardiomyopathy. And she had presented with a cardiac arrest during sleep. Her partner performed CPR. And when she was worked up with a cardiac MRI, she was found to have a severely dilated left ventricle with an ejection fraction of 35%. So essentially quite severe heart failure. There was a known variant when she went for genetic testing, and she had an in situ defibrillator, which fortunately she had not required any shocks from. She was on 3 medications that are outlined below. And in the context of time, we know that we can use bisoprolol and eplerenone in pregnancy, but we avoid drugs such as Entresto. So she was established and stable on these drugs, but not all can be used in pregnancy. So the patient was reasonably well. She was able to exercise 1 or 2 times a week, and she didn't have any signs of heart failure. She attended with her partner. She was working. She wasn't a smoker or didn't drink any alcohol, and she was using contraception to avoid an unplanned pregnancy. So this is a condition that we see very frequently referred to our clinic because it can be caused by a number of problems, but about 20 to 35% of dilated cardiomyopathies are genetic in nature. And so, what we have to think about is if we were to enable a woman like this to become pregnant, what are the risk factors? And the things that we worry about most are those patients who have a poor functional status, so they're really struggling to go about day-to-day activities, or if they have ejection fraction that's less than 40. And this is because we recognize that those women are going to really struggle as the pregnancy progresses. This is from the WHO maternal risk calculator, and you can see here that we break down the women depending on the level of the degree of disease. And this lady had an ejection fraction of 35%, and therefore it's likely in about 19 to 27% of these women that they would have a significant event during pregnancy that could affect their life and potentially risk death. So it's really important that although we can ensure that these women can become pregnant and we can ensure that they can have babies that may not carry the genetic problem, that we are making sure that we think, is the mother safe to carry that pregnancy, or should they use other options such as surrogacy and or think about adoption? So the primary problem with cardiac disease is that your cardiac output, the amount of blood going through the heart, increases by 50% in pregnancy. That means that the heart has to work a lot harder. And this increase happens very early in pregnancy. And the amount the heart has to work goes up throughout pregnancy. It reaches its maximum at 20 weeks. But there's then also a period during labour where you deliver the baby, and all of the blood that was in the placenta then moves back or auto-transfuses back into the woman's circulation. So we have to be really careful around the time of delivery and in the postpartum period. So lots of the discussions we have when patients are referred to us in our pre-pregnancy counselling clinic is that if you have a poor cardiac status going into pregnancy, it is possible that you will deteriorate very early on. And when we say deteriorate, we mean go into heart failure, risk requiring an early heart transplant, which may have been preventable, or even have admissions where the patient becomes very much at risk. So we consider termination of pregnancy in those cases. If they happen later in pregnancy, they're not also without their risk because women may have to have multiple admissions to hospital. We can often manage the heart failure, but if the woman becomes so sick that they're better to not be pregnant, we would prioritize the mother, and babies can often be left delivered preterm. Not all of the cardiac function improves postpartum, so we have to be very careful about this. So in terms of other common conditions, two of the things that I've been asked to talk about are Marfan syndrome, and this is because 80% of women who have Marfan syndrome have some involvement of cardiac disease also. The primary risk is that of aortic root dilatation, and we know that the risk overall outside of pregnancy is about 3%, but in those patients who have progressive aortic dilatation in pregnancy, or if the root is more than 4 centimeters pre-pregnancy, they're at increased risk. 1 in 10 women may risk aortic dissection. That's a significant problem because it requires urgent emergency care, and the risk of mortality is significant. So we want to make sure that any patient who's referred with Marfan's has a echocardiogram, or if not, a cardiac MRI to look at the aortic root. Pregnancy is contraindicated if the aortic root is more than 4.5 centimeters, and in some cases we're able to offer, with our cardiac surgeons, aortic root replacement prior to pregnancy, establish them on drugs such as beta blockers that can reduce the rate of dilatation. But the women really need to know that these are high-risk pregnancies, and as they progress through their pregnancy, they're going to need repeated hospital attendances. They're going to need to be looked after in a hospital where we can manage complex cardiac disease. And so it's just super important that these patients go into the pregnancy with their eyes open, and understand the risks that they're taking, not only for them, but for their partners, in terms of if the mother becomes very sick or takes a period of time after delivery to recover, if they recover fully at all, the implications that that's going to have on them as a family. And finally, cystic fibrosis, which this is the commonest autosomal recessive disorder that we see in the UK. And it causes dysfunction of the exocrine glands, where you essentially get too much mucus produced in the lungs, in the pancreas, causing exocrine pancreatic dysfunction, but also in the ovaries, and had previously led to significant problems with fertility. However, there has been an introduction of these CTFR modulator therapies, which essentially can undo the underlying problem at a protein level. And the results of this have been absolutely fantastic. Women are now not having repeated hospital admissions, have better quality of life and better survival rates. And you can see here that since the introduction of these drugs, the number of people pursuing pregnancy who have cystic fibrosis has doubled, if not more. There are limited safety data for these drugs, but if you find a lady who or patient who is taking the Kaftrio, they will not want to stop it because they recognize that it improves their outcome so much. Data in animals is safe. Case series have been reassuring, and overall on benefit and outweighing risks, we continue it in pregnancy. So what's the effect of pregnancy on cystic fibrosis? Well, this is a study that was done here. This is a Toronto study, and you can see that actually the long-term survival of patients who've been pregnant is higher than that of never pregnant. And I think that's because women who have better disease will be able to consider and enter pregnancy. But certainly this study with other studies has demonstrated that pregnancy itself doesn't have significant implications on the survival of a patient with CF. The caveat being that if the patient has an underlying infection, capacia is something that we worry about significantly because we know it's associated with significant reduction in lung function, that's when we start to run into problems. So we consider the mother's weight pre-pregnancy, how nutritionally replete she is. We worry about patients that have recent infections, and we worry about the rare risk of pulmonary hypertension in these patients, although thankfully, with the advent of these new drugs, we're seeing these less frequently. So we counsel women that if they have a history of pulmonary hypertension, cyanosis, hypoxia, or severe lung disease, which that we would recommend that they avoid pregnancy because the lungs don't have the same capacity as the heart does to adapt in pregnancy. Plus, you imagine a gravid uterus pushing up the lungs, it can become very difficult. Therefore, up to 25% of these babies, if their woman has severe lung disease, will be born preterm. And if there is a state of chronic hypoxia, there is an increased risk of small babies, fetal growth restriction, and therefore low birth weight. So in terms of pre-pregnancy counselling, we recommend that background of cystic fibrosis should not cause problems if you have good lung volumes, i.e. an FEV1 of over 70 to 80%. If it's less than 30 to 40%, we recommend that a woman should not consider this, or if they have evidence of any heart failure or pulmonary hypertension. We worry about underlying infections. We like to ensure that the woman is as well, has a good nutrition as possible. And we are aware of the 20% risk of diabetes in pregnancy in these women. So in terms of the final slide for this, we want to make sure that pre-pregnancy, there's lots that we can do for women with cystic fibrosis to make sure that they're plugged into the correct teams, that they have their chest physio, treated infections, and that they're aware that they may require hospital admissions. There's a risk of preterm birth, and we want to make sure that they're plugged into the multidisciplinary team. So to conclude, we have an increasing number of women who are going through high-risk pregnancies. We now recognise that medical complications represent the leading cause of death, and this gives us an opportunity to work with the PG teams, the geneticists, and to ensure that women are counselled appropriately so that they have a safe pregnancy. There are pre-pregnancy counselling clinics available throughout the UK now, but we accept patients to our service from anywhere in the UK. This is my email address. You can email me to refer, and if we can offer you something more local, we would. I should acknowledge my boss, Professor Nelson Piercy, whose clinic I've been doing while she's on a sabbatical and has taught me lots about these conditions.
So now following on from Melanie, we have Professor Frances Flinter. Frances is a trustee at PET and she is an emeritus professor of clinical genetics at King's College London. She's a member of the Human Fertilisation and Embryology Authority and of the Nuffield Council on Bioethics. She's a very busy lady, even though she's retired. And she is the co-editor of the book The Genetics of Renal Disease and a contributor to many books, including Preimplantation, Genetic Diagnosis in Clinical Practice and The Troubled Helix.
So one of the roles I have now is I chair the committee at the HFEA, which is called the Statutory Approvals Committee, known as SAC for short. And that is the committee that decides which genetic conditions inherited in a Mendelian fashion should have a license for PGT. And that's because conditions can only be tested for once they've been considered by the authority and felt to comply with the legal criteria related both to the risk of transmission and the seriousness of the symptoms in somebody affected by the genetic abnormality that the clinic wants to test for. So chromosome translocations and other rearrangements are licensed as a large group. Centres don't need to make an individual application for each couple for that. But the Mendelian disorders, those that are inherited in an autosomal recessive, autosomal dominant, or X-linked in fashion, each of those has to have a specific license. Once a condition is licensed, then any centre can offer PGT for that conditions. And hopefully Annalise can put in the chat the link to the HFEA website, which shows you all the conditions that are currently licensed. And actually the number's closer to 1,900 now, 1,900. And also on that list, you will find some that are due to be considered so people can see which conditions are about to be reviewed by the Statutory Approvals Committee. Now, this committee meets every month, 12 times a year, and it's made up of members of the authority. And it also has a specialist advisor each meeting, who's usually a very senior, experienced clinical geneticist. And it has a legal advisor and also members of the Secretariat. And I think it's important to emphasise that the applications that we consider have come from PGT centres who have just seen a couple who are requesting PGT for a condition which is not yet licensed. And that is because the couple knows that they are at increased risk of having a pregnancy affected by that particular condition. And these couples often already have experience of the condition, either because one of them is affected themselves or because they've previously had an affected child or there have been affected children in close relatives. And the centre that applies for a licence is responsible for counselling the couple about all their reproductive options, and there are many other things that they could consider as well as PGT. And the centre is also responsible for making sure that the couple knows what current treatments are available and how the management of some of these serious conditions is changing. And we've just had a very good example about the great leap forward that there has been recently in treatment for cystic fibrosis. And it may be that at some point in the future, the HFEA decides that it is no longer appropriate for a certain condition to have a license if effectively curative treatment becomes available. Now, when the applicant applies for a license, they complete a very detailed form. And at the top of that is the OMIM number. There's a very good online database called Online Mendelian Inheritance in Man, OMIM. And anybody can access that and can look up all the different genetic conditions that they are and can see which unique reference number that particular genetic condition has. Now, conditions often have more than one number. They'll have one number for the phenotype, that's for the clinical description, and they'll have a separate number for the gene or genes which can be involved. And we consider applications using the phenotype number because what we're interested in is how does the condition affect people clinically? And if a phenotype is licensed, then alterations in a number of different genes that cause that particular phenotype would be allowed. The applicant has to tell us at what age that condition typically presents. They have to describe the clinical course of that condition and explain to us how variable the severity can be. And they also are required to tell us about the sort of treatments that are available. These may not be curative, they may often be supportive for genetic conditions, but we want to know about those. And they have to tell us whether or not carriers are likely to be clinically affected. And before the committee meets, those applications are sent out to expert peer reviewers who will comment in detail on the application, focusing on the accuracy and pointing out any missing information that they think the committee would benefit from. And the peer reviewer will also tell the committee if they think there are other very similar conditions that should be licensed at the same time. And for example, if you look at epidermolysis bullosa on the HFEA list, there are many different types of epidermolysis bullosa. The original application may well have just been for one particular type, but the committee will have taken the opportunity to consider the other types if they are clinically very similar and it seems appropriate to license them at the same time. Increasingly now, the committee can also benefit from looking at the Genomics England panel app, which helps us identify how much evidence there is for particular genes to be involved in certain genetic conditions. And finally, the committee has the benefit of very detailed reports which are prepared for us by Genetic Alliance. And I know Nick Meade's going to talk about that in a minute, so I won't say very much more about those, except to point out how incredibly grateful we are for those reports, because what they do is provide the committee members with detailed views from people with lived experience of those particular conditions. And that tells us exactly how these conditions not only affect the people in the family who have inherited them, but also the parents and other people around who help to look after those conditions. And feedback on any application that is pending is in fact welcome from any member of the public or any doctor or anybody else who has knowledge of the condition being considered. And people can report to the HFEA directly. I think the link is just going up in the website, and can tell us what they think about whether an application that's been made and what their views are as to whether or not that's a condition that should be licensed for treatment. So having gathered all that information together, the committee meets and considers all the paperwork that it's been given. And the discussion that we have follows a regular path. So first of all, what would be the purpose of testing? And there are three main categories. The first one could be that people want to test for a particular genetic abnormality that would affect the capability of a pregnancy resulting in a live birth. The second category, which is by far and away the one that is most frequently used, is that the purpose of testing would be because there is a particular risk that an embryo would have a genetic abnormality inherited in a Mendelian fashion. And the third category, which comes up very rarely nowadays, is that the purpose of testing would be to establish the sex of the embryo because of a gender-related serious medical condition. If you go back 10 or 20 years, many X-linked disorders hadn't actually been mapped, and so we didn't know the gene in question. And so the only way people could try and avoid having an affected pregnancy would be by excluding male embryos. But because the vast majority of X-linked conditions have now been mapped, it's extremely unusual for people to apply for a license for sexing. And of course, sexing for social reasons is illegal in the UK. So then our discussion goes on to consider two things: the significance of the risk and the seriousness of the condition. So we ask, is there a significant risk that an embryo or person inheriting that genetic abnormality will have or develop a serious physical or mental illness? Now, many genetic conditions are actually very variable. They may be much more severe in some people than in others. And when we're making a decision about whether or not to issue a license, we consider the worst case scenario. So how severe can this illness be in people who are most severely affected? And we have three options when we're making a decision. We may agree to license the condition. We may decline to license the condition. Or very occasionally, we agree to issue a license just for one particular couple, perhaps because they have been, the people in their family have been exceptionally severely affected, or because for them it's a newly identified gene. There's a lot of scientific work confirming that that is definitely the genetic alteration that's caused the abnormality in their family. But there may be so few other families reported in the world literature yet that it would feel a little premature to license genetic testing for that particular condition for anybody until more evidence has become available that would enable us with confidence to license the condition. And at a later date, licenses may be withdrawn if the treatment available for that condition changes significantly. And from time to time, we do review all the conditions which currently have a license and consider whether it's still appropriate for those licenses to be in place. If a license is declined, a centre can appeal if they have more information that they could send to us that perhaps we didn't have when we first considered it. Just a final comment about microdeletions, which were asked from time to time. What should be the process for centres that are considering offering PGT for microdeletions? Many microdeletions have an OMIM number. Effectively, they're recognised as syndromes. The phenotype is clearly described. And if that is the case, then people can apply for a licence just as they would for any other Mendelian disorder. And of course, the microdeletions will generally be inherited in an autosomal dominant fashion. If they're larger chromosome deletions, and it's more like the effect of inheriting an unbalanced chromosome translocation, then the licence for chromosome conditions will cover that. And just as a final comment, two other duties of the statutory approval committees. We also consider applications for mitochondrial replacement therapies and for HLA typing if people are requesting that for a condition that hasn't yet been licensed. And finally, the committee is responsible for issuing special directions to clinics about rules for the import or export of eggs, sperm, or embryos to or from other countries.
Our next speaker is Nick Meade. At PET, we've known Nick for many, many. I've known Nick, I think, all the time I've been at PET, as is Sandy. He's sort of like it's a colleague working in another office. We've dealt with him so often over the years, so it's a really great pleasure now to introduce him. He's Director of Policy at Genetic Alliance UK and co-author of research into the care experiences of people living with rare conditions. Nick serves on working groups at the UK National Screening Committee, the National Institute for Health and Care Research, and at Genomics England's Newborn Genomes Programme.
As you've said, and as Francis mentioned, I'm going to explain what Genetic Alliance UK does to ensure the voice of our community is seen by the Statutory Approvals Committee, and talk a bit about why PGT is so important to our community too. So just before I get going, though, I want to thank all the people living with genetic rare and undiagnosed conditions that contribute to our work. and to thank our member organisations. Of course, as an umbrella organisation representing such a big community, we can't do anything without you all sharing your stories and experiences. And just to acknowledge that though we know our community prefer us to talk about people living with rare or genetic conditions, occasionally policy does talk about patients with rare diseases, and so we occasionally have to say those words as well. You can find out more about what we are as a charity at genetical.org.uk. We've got more than 200 member organisations that support people living with genetic rare and undiagnosed conditions. We're a small team working in policy and research, and we run the Swan UK support network for people living with children with undiagnosed conditions. And we organise Rare Disease Day, which is fast approaching. And we also work to ensure that parliamentarians in the UK are aware of the issues affecting our community. So I said I'd say why it's important, and this is, I think, an interesting way to look at preimplantation genetic testing. Just to take you around this story here, the government counts more than 7,000 rare conditions. There's lots of different ways to count them, but I'm happy to go with that very big number. It's definitely representative of the picture that we see. And then Eurodis here publish data regularly about medicine development for rare conditions. So these numbers here are saying that there have been more than 3,000 promising ideas for a medicine for a rare condition, but only just under 270 medicines have actually made it to market in the EU. And until recently, that was the same market as us, and those numbers essentially work for us as well. And then only 100 of those are available for children. Those numbers are further reduced by the fact that in the UK, this stat here is for England. We don't pay for all of those medicines, so they may be legally permitted to be marketed here, but the NHS is not paying for them because they're not judged clinically cost effective, sorry. And sometimes they are available, but not to the whole population that could benefit from the treatment. Of course, it's true that there are other treatments for rare conditions too. So bone marrow transplantation, dietary supplements or changes. There are some conditions that can be successfully treated, but with lots of surgeries or transplantation. The burden of treatment there is often really very high and can include a great deal of risk to the person concerned as well. So it's fair to say that for those 7,000 rare conditions, most of them don't have course-changing treatment. So we think that for couples at significant risk, preimplantation genetic testing is the best way for them to take control of the way those conditions are affecting their families. And as Francis has mentioned, it's available for 1,900 conditions, which is around 30% of that 7,000 rare conditions I mentioned at the beginning of this slide. So that's why we put quite a lot of effort into making sure that Frances and her colleagues at the SAC committee are informed of the experience of our community with these individual conditions. So this is the pathway we go through when we're generating the statements that we deliver to the committee. We try to do it as quickly as possible, of course, but the timescale is between 4 and 7 weeks. These applications can come in big clumps, so it can be quite challenging for our small team to deal with. We start off by trying to find representatives of the community that we need to access. We start with our members, of course, but we don't solely focus on our members. We look at UK charities. A lot of the rare disease community is convening on Facebook now, so we look on those networks too, and we also will contact organisations around the world. Our next key decision is whether we need to generate voice from this community ourselves by creating a survey. And we consider lots of factors there. What's the impact going to be on the community to have this survey out there? Is that going to be a harm in itself? Is that testimony available already? And does the support organisation concerned have a recent survey or resources that can help us? And of course, is this condition so rare that we might not get any responses at all? I think the biggest innovation that we've had over the years of doing this is to transmit as much first person voice as possible to the committee. And I think this is illustrated best well by a condition that we prepared a response for a few months ago, dentinogenesis imperfecta, where instead of us saying that fragile teeth can cause self-esteem issues, we had direct quotes from young people who had messages like "I hate my teeth" or stories of how they hide from their significant others while they're cleaning their teeth. I think that really does bring to life the experience of the condition for the committee. So I think it's important to note that we don't publish our statements. They're focused on the needs of the committee. Our members and the people and other organisations that support people with rare conditions are much better at targeted communication for people that are receiving a diagnosis for a rare condition. And we don't think it's right to have these statements Googleable and findable by accident. And then we also have some feedback. So we have a great relationship with the team that administrate the decision-making process, and they give us great feedback to improve the statements that we make. And we also feedback to the communities that contribute so that they find out as quickly as possible when the licensing decision's been made. I wanted to I don't want to focus on individual conditions because the variety in rare conditions is so broad. But here are just a couple of quotes that begin to show some of the richness of the dialogue that we're able to transmit. This first one shows that, well, I think that the strength of feeling of support for preimplantation genetic testing is a reproductive choice. And I wouldn't get this message wrong here. This isn't saying that all of people at risk of pregnancies affected by rare conditions decide not to have children unless they can have PGT. That's definitely not the case. But it certainly is influencing an awful lot of reproductive decision making and people's plans. And I think this begins to show the kind of the psychological factors that people are making decisions on here, not just the kind of clinical impact of the condition. And so when we're writing our statements, we're trying to show both the familial and social impact of the condition. We're talking, I think, often as much about the burden and impact of treatment as we are about the condition, and either where there's no treatment or that the treatment itself is actually creating a lot of the burden that people are traveling to hospital, taking time out of school, and so on. A late onset condition is not a less serious condition. The condition's hanging over you, especially in the context of the known familial risk. And also for dominant conditions, having a condition that goes back through your family can also amplify the impact of the condition for people concerned. I know I'm running out of time, Sarah, so I'll just stress that I think we play an important role to make sure our community is aware of the call for evidence. It's there for everyone to respond to, but we can help make sure the right people see this opportunity. And we also can help a community that might be getting to grips with reproductive choice decision making for the first time as the genetic diagnosis kind of lands in their community, and the opportunity becomes clear to see that this is available for lots of other rare disease communities, and for them to get to grips with the opportunity and the kind of decisions they need to go through in sharing information about their condition for decision making. We have now submitted 618 statements, and actually, for as an umbrella organisation, it's not that clear often when you have a direct impact on individuals concerned, and this is one of the ways that we do have that impact. So it's greatly valued. I mentioned we've got a great relationship with the people that administer this, and I'd like to thank the committee for their feedback, which has really helped us improve the process. And we've been doing this for 15 years, and there's been lots of my colleagues that have contributed to the process that we deliver.
So we're going to be moving on now um, to Diana Perry. And Diana is sort of has come to the panel through Nick and Genetic Alliance UK. So I'm very grateful to Nick for recommending her because she is the founder and chief executive of the Ectodermal Dysplasia Society, and she is the mother of two children with ectodermal dysplasia. And I'm sure she'll be explaining what that means and in the context of PGT.
I've been given the task of barriers to accessing PGT-M from our family's point of view. So the first thing is a cost barrier. So the cost of a single cycle of PGT in a private setting can exceed £12,000, which for many families, this is very prohibitively expensive. So NHS is our next port of call, who, as you know, provide cycles of IVF with PGT. But as we know, even if the PGT is covered by the NHS, the financial strain, as mentioned earlier, for our families can still be significant due to travel and accommodation expenses. So if we then move to the geographic barriers, I didn't realise this, and it's amazing. As you can see, these barriers exacerbate the inequalities, particularly for families in the less affluent regions of the UK. I'm sorry, but these figures are hugely out of date, but it's all I could find on Google. So in 2020, there were only 39 clinics in London, 24 in the southeast. Yorkshire, Humber, and North East just had 7 clinics each, and there are very few in the southwest. So geographically, that creates huge barriers for our families. So the complexity of the genetic conditions and licenses, while certain genetic conditions are eligible for PGT, only a limited number are licensed. So the group of ectodermal dysplasia conditions include up to 180 different syndromes. And out of those, only 31 are able to have PGT screening. So the complexity of that is it requires the families to undergo multiple rounds of testing to clarify that the genes and the genetic variants are looked into. So I just wanted to give a case study. So very briefly, I'm not sure how many of you know about ectodermal dysplasia, but it's a life-threatening condition in that the sweat glands are either missing, non-functioning, or basically it's lack of temperature control. But the teeth are a second major symptom, which is interesting, following on from what Nick has just said, because all the teeth can be missing, or any teeth that are present may be misshapen, i.e. the 2 front teeth can be just very, very pointed and very sharp. And that requires a lot of dental work, dentures from the age of 3.5, which they then have to wear until they are fully grown, and can then go on to have implants. So those are the 2 major things, but lots of other parts of the body are involved as well. As you can see, the infant mortality rate is quite high. And that's largely due to the fact that they can't sweat, doctors don't understand what's going on, and things all go wrong. So naturally living with this condition and being able to do lots of things because of the overheating, the hypothermia, lethargy, lack of concentration, looking different, being bullied throughout their life, it causes some people to not want their children to go through all the things that they have. I will add in here that as a society, we it doesn't matter to us whether you want a child with ED or you want a child without ED. My job is to give you all the information that I possibly can so that you and a partner can make an informed decision for yourselves. So going on to a diagnosis and testing, this is a sort of breakdown of a family who are still going through the process. So you can see from the timeline, they started in 2022. And then it was waiting lists, waiting for appointments, getting the testing, and then getting the confirmation. And having got to that stage in December, they can now go through for PGT, but they now have to wait for a clinic to accept them. And then I think things begin to start speeding up. But you can see the length of time it takes when you're a family and you want to start your own family. This time frame is hugely long. Most people would like to get pregnant within a year. So it's, you know, there are emotional, ethical, and logistical complexities to all of it. So if we go through this, we go halfway down, what the family, their decision to pursue is because in this family's case, because it's X-linked, they want to prevent their daughters from inheriting the XLH-ED. And the only way to do that is by PGT and only allowing male embryos to go forward. So while females are typically have milder symptoms, but not always, I might add, they carry the risk of passing it on to all their children. And that perpetuates the cycle of the challenges and the medical concerns. So in this case, they want to obliterate it from the family. And they can see that this is the only way to go forward. However, they have a fear of failure if the process doesn't work, or the timeline extends even further. They're getting older. Resentment of the delays, the waiting period, as I say, can take a lot of time, and that's a lot of precious time that's wasted. And then there's worry for future generations. The family's commitment to preventing XLH-ED underscores a deep love for their future children and a desire to protect them from suffering in the same way that they have. So the conclusion is the barriers to accessing PGT in the UK are significant, both financially and geographically. So while the NHS offers some support, the limitations in coverage and the long wait times can make the process emotionally and financially exhausting for families. The concentration of clinics in the Southeast exacerbates inequalities, and the complexity of the genetic conditions, along with the limited number of licensed conditions, add further complications. So the broader implications would be to reduce waiting times, streamline diagnostic processes, expand access to PGT. And these improvements would not only alleviate uncertainty for our families, but also enhance the overall efficiency in genetic healthcare systems. One thing, going back to what Francis was saying about how sometimes they take a license away, we are undergoing a treatment trial at the moment, but this isn't a curative treatment trial. This only corrects symptoms. And it's hugely groundbreaking information where many years ago, synthetic protein was designed in Switzerland, and it's to correct the major symptoms, which we're hoping are the sweat glands and the teeth. Anything else will be a bonus. So this has got to the stage now, since the 1980s, it's got to the stage where we can now apply it in utero, and that's done between 26 and 32 weeks. The successes that we've had so far is that these children can sweat, which is amazing because that will change so much of their life. They can play football, they can go to hot countries, all these sort of things. And the other significant issue is that we're hoping to reduce the severity of the dental abnormalities. But at the moment, the trials, the children haven't got old enough for us to be able to see whether they have got more teeth or not. So that's exciting news for us. So for families not wishing to undertake PGT, the success of this therapy is it's another way of correcting the symptoms so that their children don't suffer in the same way that they have suffered. So it represents a milestone of achievement. And for families affected by XLHD, it's a source of hope that science is closing the gap between diagnosis and meaningful treatment. So you can see the aspirations of the families, their dream of where they'll be symptom-free, the protein therapy. It's all very exciting. But going back to the challenges and constraints, the NHS is under strain, as we all know, with long waiting lists for genetic services, delays in appointments, and limited access to reproductive technologies like PGT. So these delays not only cause emotional stress for families, but also undermine the potential benefits of scientific advancements. Yes, we provide a vital role, excuse me, in bridging that gap between us and the healthcare. We advocate for quicker implementation. We raise awareness about the importance of funding and prioritising genetic healthcare, and supporting families through any complex journeys that they decide to go down, irrespective of what we think or feel. We take the journey with them. And if I may, one plug. Oh no, I've still got one more slide. I beg your pardon. Yes. So our vision for the future is that we hope genetic conditions no longer a distant dream, but an achievable goal with the right combination of research funding and healthcare reform. The integrating preventative medicine and early intervention into standard healthcare practice, the NHS can transform the approach from managing symptoms to eradicating conditions. So for all this to materialise, the partnership between families, advocacy organisation and healthcare providers must remain strong. Continued investment in genetic healthcare and reproduction, technology coupled with a commitment to reducing system delays will not only bring relief to individual families, but also create a healthier and more efficient NHS, and are not just patients, but key stakeholders in pushing forward the evolution of care. So I hope this presentation has captured some of the aspirations of our families. I could talk for England and go on all night about our families and how they're affected and the obstacles they come up against. But hopefully this has highlighted the delicate balance between the scientific advancements, healthcare system constraints, geographic availability, and patient hopes. And as I was about to say, I just want to plug this in that if you would like to know more about ectodermal dysplasia, you can join us in Birmingham in June for our international conference. It's all on our website if you want to take a look. So thank you from me, and thank you for everyone at the ED Society for all the work that you all do.
So we've got lots of questions, so I'm going to start putting them to the panel now. I'm going to start with one from Christopher Wild, and he ask this of Charlotte. It says, does the UK have sufficient capacity of genetic counsellors to adequately meet the needs of the growing number of patients undergoing PGT?
No, we don't have enough genetic counselling workforce for, as you've seen exemplified here, routine clinical genetic services. So there is investment in that the new genomics unit within England commissioned the STP genomic counselling pathway, but there has been a lack of investment in the higher levels to provide training posts to help support those genetic counsellors because they do a lot of on the job training over the 3 years. And we've had an exodus of retired genetic counsellors that sort of set up the profession 30 years ago. So similarly for geneticists, there isn't the workforce there for genetic services within the NHS or potentially for the growing aspect of PGT.
Does anyone else want to comment on that? Diana.
Yeah, can I just say, with all respect to all your counsellors who do a wonderful job, um, for the family that I spoke about, they actually knew more about the condition than the geneticists did. And it made it very difficult because the geneticists have to go by the rules and the books and spell it all out to the families, which they find equally exasperating. Um, but equally, you can't have counsellors up and down the country knowing about every rare genetic condition.
Mm-hmm.
And this is where we can come in as organisations, because certainly in our case, 25 years of doing this, we know the condition in and out. And we can help bridge that gap with the counsellors and the families. So what I'm always trying to do is bring more awareness of our society and other charities similar to ours that we need to be used by yourselves so that we can bridge those gaps and take away some of the work from you. I'm not sure I'm explaining this very well, but we don't get used enough by the medical professionals, and we could help them.
I mean, I guess it sounds like whether there's more of a possibility of, so NHS, let's say, for example, NHS England funding for PGT, it stipulates referral from a clinical genetic service, and
Yeah.
whether there's the possibility, of, I'm just thinking, say, with Huntington's disease, there used to be the model that HDA advisors could refer patients in, and that maybe that needs to be sort of looked at more, as well as the expert information you could provide to us when actually working with genetic counsellors.
Yeah, I mean, we wouldn't be able to refer anybody because we're not medical people. But if genetic counsellors come across something like ED or whatever the rare disease is, if they go to organisations like ours, we can help them learn and understand about it before they meet the family. Because I found with this particular family, everything they said, they felt that they weren't believed, and the counsellors had to go away and Google it and find out about it, and then make another appointment, which is another 4 months down the line. Whereas it had been much quicker if they'd have come to us direct, the counsellors themselves, so that would close yet another gap. Yeah.
Yeah, it is. It's that challenge of, as Nick said, 7,000 different conditions,
Yeah.
and that time in preparing. But yes, we're hearing you that about trying to develop those links with charities, and I know the agency is working on trying to focus that as an area for genetic counselling.
That would be good.
Okay, if no one else wants to come in on that one, I'm going to go to the next one, which is from someone who's chosen to be anonymous. He says, am I not correct in thinking the embryos can be sent for the testing without the couples having to travel? So I suppose why could people not have treatment locally, I suppose is the point he's meaning, and then the embryos be sent to testing wherever the centre for testing is. Is anyone want to come up with a reason why? Don't know whether Charlotte or Francis.
Um, so I'm just thinking. I think some services will, rather than sending embryos, they will potentially biopsy and extract the cells, and they can be sent on to the genetic labs that the PGT services have contracts with. Within our own service, so to be able to do that, you have to be accredited through UCAS to provide that service, and it's not something that our service within our NHS restricted lab has been able to do at this point. But I think that is technically possible. There was another. The one thing I'd say is that the type of genetic testing you do on, say, 8 cells extracted from each embryo is quite specific and tailored as compared to, say, DNA or a blood sample taken from a patient where you have a huge amount of DNA that you to work with. So it's not that any lab could potentially do that testing. They do still need to be, as part of their scope of practice and their accreditation, that they are able to deliver these tests.
Okay. No one else wants to come in on that one. Okay. Then we have one from Michael Lepage from New Scientist. I was surprised to hear that the HFEA might withdraw the license for PGT if a curative treatment exists. What does curative mean here? Just as good as not having a mutation, 90% as good. Would the cost of the treatment be taken into account? And the inconvenience or risk of non-compliance for the individual of requiring, e.g., regular pills or injections or I don't know, surgeries even. So I think Francis, you raised this first in your, so if you want to go first on this one.
Yes, well, if we look at what is laid down in the law, we issue licenses if there is a significant risk of serious disease. It's extremely unusual for licenses to be withdrawn because the vast majority of genetic conditions don't yet have a curative treatment. But it would be wrong if we didn't review the licenses from time to time to make sure that it was still appropriate to have a license for that condition. Obviously, it's not just a question of some trial treatment being available in one place. It would have to be a treatment that was thoroughly validated, readily available on the NHS, that we knew all about the risks and the pros and the cons and so on. And we would have to be confident that that treatment meant that people with that condition receiving that treatment were not at significant risk of serious disease.
Sorry, I'm probably asking you a bit to speculate here. And would that then involve some contribution, that process, from people who'd had the treatment and were living or were parents of if they were young children, of those to sort of calculate the sort of the burden of those treatments, Francis?
So
Right, and then I'll come to you, Nick.
we ask our expert peer reviewers to comment from time to time on conditions for which there is currently a license. And they would let us know if a treatment was available. Obviously, we would need to know a lot about what that particular treatment involved and how readily available it was and so on before we could make any decision about deciding to remove a license. So I think it's something that is potentially on the horizon for a small number of conditions. I don't think it's something that is likely to happen in significant numbers for quite some time, despite all the enormous research effort that is going into finding successful treatments or even cures for these genetic conditions. And obviously the committee would only make a decision when guided by not only experts in the treatment of that particular condition, but also the sort of information that Nick has described that he can obtain for us from affected families.
Nick, I think you wanted to come in.
Yeah, thank you. And we'd definitely be keen to carry out the same process. In the past, we have been asked to participate in some of these reviews, but I can't recall the last time that we were asked to contribute. So I think the burden of treatment is really, really important here. So if you think about the most innovative, most powerful medicines that are really amazingly welcome to our community. They're changing the trajectories of many people's lives. Some of the gene therapies that we're seeing, some of the cell therapies, you need to be near an intensive care unit for when you're treated, which I would say is a burden that's a little bit too high to consider taking away that reproductive choice opportunity. I think Michael mentioned cost of treatment, and I think that is worth a societal debate when the question comes. If we are opting to take away effective PGT from families to put a six-figure sum onto the NHS for every time PGT isn't used, I think that's a very interesting question. I understand that the law at the moment would essentially say if that treatment was completely burden-free and very highly effective, would probably land on us having to take away that license. But I think I'd be keen that we have a detailed debate about that before it happens.
Yes.
Okay. So the next question is one for Melanie from Karen Sage, and she asks, are you able to provide support for surrogacy if pre-pregnancy counselling recommends a female patient doesn't proceed with PGT-M given the risk?
Um, Thank you, Sarah. So I think I should first just double check with Charlotte and Francis that I can't see any reason why, if you have PGT, you couldn't then use a surrogate. But before I go any further, I probably should just double check that.
Yeah, some of our patients do, but obviously it's just that complexity. Obviously, the surrogacy is completely unlinked to the PGT, but
Yeah.
our assisted conception unit has a donor and surrogacy specialist and pathway.
Yeah. And so, I mean, in terms of pre-pregnancy counselling, it's something that we always discuss because the risk that a family are prepared to take differs, of course, by individual families. So we have an initial discussion about that during the pre-pregnancy counselling session, and then we do work very closely with our assisted conception unit to go and have a discussion about that, and then refer to some of the charities for surrogacy as well for additional information.
Great. Does anyone else want to come in? No, I thought someone to put their hand up then. Okay. The next question is for you, Charlotte, in the first instance, and that's from Amy Cohen. She asks, how did you find it with embryologists delivering the results, especially if there are no embryos suitable for transfer, or there are more complicated results such as mosaicism?
Our embryology colleagues are highly trained in, I guess, breaking that difficult news. It's something they do as part of their routine work within our service for PGT and I guess for our IVF patients that are in ACU. If there is a complex genetics result, then we would usually offer either the genetic counsellors may give the result in place of the embryologist, or we would do a follow-up call very shortly after.
Great. Okay. Um, right, I've got quite a long question next from someone who's anonymous saying the fact that 60% of PGT is done at Guy's and St Thomas's seems problematic. Why aren't more regional options available? Patients shouldn't have to travel over long distances, presumably at their own cost and away from the support of friends and family, and away from the medical teams they're familiar with. Biopsy specimens can be sent to expert genetic labs thousands of miles away with no decline in the quality of results. So why can't the whole IVF cycle be completed locally and the embryo samples be sent away? Additionally, shouldn't patients have the flexibility to choose the IVF clinic with the highest pregnancy rates and the genetics lab with the highest accuracy? That would also seem to deliver better value for the NHS as well as better outcomes for patients. So quite a long question, but I think it's probably for you, Charlotte, in the first instance.
Yeah, so I guess I've addressed slightly the need for any labs that accept DNA or cells from an embryo to have that within their scope of UK UCAS accredited practice. The one, I mean, I think I would agree that across the UK there could be better service provision in the regions. The one thing that also has to be taken into account is that because of the nature of PGT, some of these female patients have these genetic conditions, and therefore the support medically they may need may not be available in some IVF centres that are standalone IVF centres. So we often are referred the patients with more complex medical needs, like Melanie has highlighted, because of the fact that we are based in a tertiary hospital service, and therefore we have got that backup and support. So that is one issue that probably needs to be considered from a medical and health perspective of these patients coming through for treatment, as to how that service provision can be provided across the regions. And I guess one of the other issues, which is, why we're waiting for the commissioning to be updated, and for it to be addressed by the NHS England commissioners around the funding and how historically PGT services have been commissioned in England. So I think it is something they are in the process of trying to address. I'm not sure if I answered all the questions there.
It was quite a long question. Do any of the other panelists want to come in on this?
I would I'm from Newcastle and I trained in Cardiff, so feel like I've worked in lots of different places, and the postcode lottery is astounding as you move to different places. And but I would agree with Charlotte in that some of the patients, and it's not going to account for all, but we provide a lot of medical support even for egg collection in certain places. So having particular anaesthetic lists for sedation, if things were to change, if a woman was to have any risks of just sort of the egg collection itself. So I think again, just there probably are many centres around the country that could support with that, but it is definitely something that needs to be considered when opening up in more centres.
Okay. If no one else wants to come in on that one, I will go to the next one. So we have someone who's asked a question to most people. One for you first, Charlotte. Does the role of genetic counsellor to patients and family include giving information on alternative options, such as gamete or embryo donation, and giving information on the actual lived experience of people and families living with the condition and disability, and facilitating conversations between the clients, parents with people and families living with the condition and disability? So if we go to you for that one first.
So usually when you're talking a individual couple through their reproductive options, then yes, one of the options would potentially be gamete or embryo donation. In addition, so would adoption, and of course we've talked about PGT, and then potentially testing in pregnancy, and also, very key that a lot of people choose to do absolutely nothing in relation to that genetic condition in their family. And obviously our job is there to provide that information and to help a couple to make the decision which is the best decision for them or that individual or their future family. We would try to give information about the lived experience, but as we've already highlighted here, there are over 7,000 different genetic conditions, and so we will have particular conditions we are more knowledgeable on. But the idea would be to certainly try and signpost people to have conversations with or contact the charities, and ideally if there are families they can talk to through those charities, or if there are specialist services, we would potentially arrange for them to have a conversation with those specialist services who are expert in trying to manage that condition. So it will be trying to sort of almost part of the role is to signpost on if we do not have all the information for that particular condition, or more information is required.
Nick.
Thanks. Just on that kind of experience of the condition, I think for dominant conditions, one of the member of the couple is likely to be affected. And then for the recessive conditions, the way that the couple have found out that they're at risk of having a pregnancy affected by the condition is usually by having an effective pregnancy, because we don't do carrier testing really very much in the UK at all. So often they have had some experience, and often they might be living with a child that already has the condition, or be grieving the loss of a child with the condition or the loss of a pregnancy affected. So a lot of the decision making is quite well informed already. I just wanted to add that as well.
And while I've got you, Nick, this person asked a question for you too. They say, you might be pleased to know they asked Dr. Meade, is it it's mentioned that a vast majority of the membership support PGT-M license as a valuable option. You said that was that part of a survey? And if so, can you share the survey?
I'm always welcome honorary doctorates, so if anyone wants to give me one, I'd love it. But we haven't surveyed our members on this actually. That fact that I'm sharing there is the result of having spent 15 years contacting our members to inform them that our conditions become licensed. Um, it's not welcome news for every single community. At which point we do remind them that a member of their community has triggered the application, and so that there is a diversity of views in their community. It's coming from that kind of conversation that my colleague actually had the conversation with Diana, and worked together on the statement for one of the ED conditions, and it's that dialogue that we've had over the past 15 years that draws that conclusion.
Francis.
Thank you, Nick. That was very helpful. I think your point about the fact that even though there is a license doesn't mean to say people should feel under any pressure at all to have PGT is really, really important. It's an option that only a minority of people who are at risk of having a child or pregnancy affected by the condition choose to have. The majority, for all sorts of reasons, will go down other paths. And so the HFEA would certainly never want to feel that this list is prescriptive and in any way implies that there is an expectation that people should consider PGT. And if I may just pick up a point that Diana made, she said only some of the forms of epidermolysis bullosa are licensed. Well, licenses are issued in response to people coming forward and saying, we would like to have PGT for this condition. So just because a condition is not on the list doesn't mean to say that it wouldn't be considered and potentially licensed if somebody put in an application. The trigger is a couple coming forward and saying we would like PGT for this. So the number of conditions licensed goes up every month. Every month we typically consider 5 or 6 new conditions, and for some of them there will be 3 or 4 different types that we might choose to license at the same time. So that number will continue to increase. And if somebody with a form of epidermolysis bullosa wishes to have PGT and their particular type isn't on the list, then they should talk to their centre about putting in an application.
Nick.
I was nodding vigorously off camera throughout Francis's response there. I just would pick up one kind of risk of inequity of access, though, with the fact that those couples in Diana's membership that don't currently have a condition or at risk of passing on a condition that isn't currently licensed, that they need to find a clinical geneticist or genetic counsellor to refer them to a PGD centre to make the license application. And if they happen to be unfortunate and have a paternalistic doctor, then they might not get that referral. I think that's less likely with ED, but with some conditions that are maybe on the edge of seriousness, I think there's a chance sometimes that paternalistic clinicians don't make the referral or close down that conversation too early in the pathway.
Francis.
I think the thing to do is to encourage any patient who has, or any person who is living with a genetic condition, if they wish to discuss their reproductive options, to seek a referral, which could be from their GP or from their healthcare specialist, to a genetics department. And I'm quite sure that genetic counsellors and clinical geneticists would always discuss all the range of reproductive options that is available, including PGT. So I think that the way to get through that funnel is to ensure that people are seen in a genetics department. Now, Diana's quite rightly raised the fact that there are really long waiting lists to be seen in genetics department, and that has got so much worse since the pandemic, unfortunately. And I know that centres are working very hard to try and reduce those waiting lists, and that is really difficult for people who are wanting to start a family this year rather than in 3 or 4 years' time. But I think I can be pretty confident in saying that that sort of paternalistic decision not to discuss all the reproductive options, you might see it, I suppose, in some specialists. I don't think you would come across that in a genetics department.
Okay, and then there's a question for you, Melanie, which I hope if you have to hand, that this person would like a link to the WHO maternal risk calculator. So if you can Google it and type it in the chat, that'd be great.
It's in the European guideline for cardiac disease and pregnancy, but I'll put a link for that in the chat now.
Fantastic, thank you. Okay, so I'm just going to go back. I'm going to go to the most upvotes because we're running out of time now. Um, for Charlotte and anyone else, what is the justification for not offering NHS-funded PGT to couples who have healthy children if they carry the same genetic risks? Um, so I'm very conscious that Charlotte didn't write the commissioning guidance, but has to justify it. No, or may not feel she has to justify it.
I'm not sure if I do have to, because I think Frances may be better able to, because she was I think maybe more aware. But I have a feeling that possibly when it was written back in 2014, it was the first guidance of its time, and I guess at that time, and there still is, isn't there? There is that there is still for a lot of healthcare professionals that confusion between PGT and IVF, and that PGT uses IVF, but its purpose is not fertility founded. But obviously, at the time, there was guidance around IVF is there to help enable people to have one child, and possibly not even that, depending on your postcode currently. But that the policy was written along the lines to enable a couple to have one child unaffected by the genetic condition, and that it was a way originally of maybe that being taken into account, that they did have a child and it was a healthy child, and didn't consider maybe that the other conditions like the later onset conditions and the impact that how that policy is written would have for those families. But Frances, I don't know if you can.
Yes, I think this tension between the extent to which commissioning policies for IVF and commissioning policies for PGT should directly align or not has caused problems throughout. I do remember when the initial policy was written, there was a lot of concern that this could be opening the floodgates because nobody really had any idea what the demand for PGT would be. And there was a real concern that this would become unaffordable and therefore mean money wasn't available, for example, to help people with primary infertility, not at risk of having a pregnancy affected by a genetic condition, but who were struggling to get access just to IVF, which is, of course, considerably cheaper. And so putting in the clause to say that couples could only have PGT if they did not already have a healthy child, I think, to use that awful word, was a way of rationing the treatment and just trying to keep the numbers down so that it was containable and affordable.
And Nick, I think you wanted to come in.
And just a tiny bit to add to Francis to make it palatable as well. The commissioning policy has been talked about for quite a few years, but the opportunity to have it written and made nationally available was with the launch of NHS England, which was then called the National Commissioning Board. And I think we did celebrate because it was one of the very few additional funding decisions that happened that year. Although it was supposed to be reviewed within the year, I think the original policy is way overdue review.
Great. So yes, we shall look forward to seeing that review. Hopefully it won't take too much longer. So we've got another anonymous question for all. How do the panelists explain or justify the difference between highly complex procedures required to permit PGT-M compared to the relative lack of scrutiny over prenatal screening, such as amniocentesis? I don't know whether of you feel qualified to answer that. Want to take a punt, Francis?
I suppose it's a question of history, isn't it? Prenatal diagnosis has been around for several decades. and the responsibility for making a decision as to whether or not a particular condition is thought to be serious enough to test for has rested with the person seeing that particular pregnant woman, and helping her decide what to do. Whereas PGT, because of the technology involved to do it, involves IVF. And of course, fertility treatment is very closely regulated in our country in a way that I have to say is regarded internationally as very effective. And I've spoken to people abroad who think that we're very lucky to have such a robust regulator in this country, because it does help protect patients and maintain standards. And there is a legal requirement for centres offering PGT to have a license for the particular conditions that they're testing for. And I think that has just happened because of the way the HFE Act came into being and because of the way fertility services more broadly are regulated.
Great, thanks, Charlotte. Thanks so much for taking that, Francis. Okay, we have another question for you from Sarah Levine, who you know. She says hi. At CRGH, we were advised by our local HFEA inspector a few years ago that for microdeletions, duplications, if the chromosome segment contains more than one gene, it doesn't count as a monogenic condition, and is covered by the PGT-SR license. And we don't need to do a specific PGT-M license application. So I'm a bit concerned that you said we should apply for licenses for them. I presume this only applies to those with phenotype omin numbers, but even so, this inconsistency is concerning, she says.
Yeah, so I think what I said, or what I meant to say, is that yes, if there is an omin number for the microdeletion, then it is appropriate to apply for a license, just as you would for any other Mendelian disorder, because effectively they're inherited in an autosomal dominant fashion. But if it's a larger deletion that is effectively the equivalent of the unbalanced product of a chromosome translocation or inversion, then it is covered, as Sarah says, by the SR license. But I think for particular cases, if there's any uncertainty, the thing to do is to contact the HFEA directly and just seek their guidance.
Great. Okay. So there are a number of other questions. I'm trying to find the best one really for you. So I think one is, what is the current waiting time for patients, Charlotte, at Guy's? Because the person says by expanding the number of centres that could perform NHS PGT-M cycles, that wouldn't that help older patients to have more than one cycle prior to the 40th birthday, or sometimes 39 cutoff?
So we would normally see patients for their initial appointment within about 2 months. And I'm fairly certain that other centres like CRGH and Care in Nottingham have similar, if not shorter, timeframes. I think there's been recently an increase in funded capacity for those centres.
Great. Well, that's good news. Then, oh gosh, second. Oh, well, we've got one on AI. Should we take that one? So this is from Anna Katuslaki, whose surname I've just now murdered. I need AI to pronounce it. I'm sorry about that, Anna. So she thanks you all and says, "What's your opinion on AI enhanced PGT? Is it promising? Is it often used at the moment? Is the HFEA planning to create relevant guidelines on its application? Is the time now to start looking at a regulatory framework for it?"
So the HFEA is watching what's happening with AI, and its Scientific and Clinical Advances Advisory Committee does look at very detailed papers about what's happening in the AI world and consider whether or not they may be helpful. I think there's still a way to go before AI can replace an experienced embryologist, for example, in terms of looking at the developing embryos and so on. But yes, it's certainly a field that we are very much aware of. And if we can produce any guidance or help for people, then we will.